There will now be an opportunity for silent prayer or meditation. Please be seated. The Secretary will now read the order.
Debate on vote number 16, Health Appropriation Bill.
I now call upon the Honourable the Minister of Health to introduce his budget vote. The Honourable Minister.
Okay.
If you're comfortable, Minister, you can use your cell phone.
Honorable Chairperson, colleague Deputy Minister of Health, Chairperson of Portfolio Committee on Health, Honorable Dunjwa, and honorable members of the Portfolio Committee, representative of UN agencies and development partners, as well as donor countries, distinguished guests, ladies and gentlemen, good afternoon. Honorable Speaker and honorable members of the House, as you know, this year we are celebrating the 100th anniversary of one of the most revered icons of our revolution, Oliver Reginald Tambo. The year has been accordingly declared the year of Oliver Tambo. Tambo has dedicated his entire life to the creation of a democratic, non-racial, sexist, and prosperous South Africa where all people, regardless of their economic or social status, will have equal rights. Tambo once declared, and I quote, "We have a vision of South Africa in which black and white shall live together as equals in conditions of peace and prosperity." To me, Honorable Speaker, the best tribute we can pay to this gallant hero of our liberation struggle is to ensure that we translate our constitution into reality, into a living organism. While we have made huge progress in the health sphere, as observed by the Statistician General yesterday, when he released the results of the South African Demographic and Survey, and I'll visit this topic later in the speech, we still have not translated very important parts of the Constitution into health reality. Only when our people enjoy the health dividends of democracy through the provisions enshrined in the Constitution shall we say our work is done and Oliver Tambo has indeed been honored. The Bill of Rights in Section 27 of the Constitution states that unequivocally that health care is a right. Subsection 2 then goes on to say, and I quote, "The state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights." And subsection 3 states, and I quote, "No one may be refused emergency medical treatment." Honorable Chairperson, the most important aspects of these provisions have not as yet been operationalized. The time has now eventually arrived for us to do so. In the second phase of our transition to democracy, the phase of radical economic transformation, we have got no option but to do so. It is for this reason that we have no option but to implement the United Nations Program of Universal Health Coverage, which in South Africa we call NHI. Those not yet fully initiated, we define NHI as a health financing system that pools funds to provide access to quality health services for all South Africans based on their health needs irrespective of their socio-economic status. This definition may as well fit in very well in the definition of a medical aid scheme, but there are two main very notable exceptions that make NHI and medical aid schemes look like chalk and cheese. The first exception is the word all. Under the NHI, we intend to pool funds for all South Africans. In medical aids, the word all does not exist. Medical aids are designed for a selected privileged few and pretends that the majority of South Africans do not exist. Yes, the system of medical aid is designed for only 16% of the population. And according to this system, 84% of the population have no right to access to good quality health services, and they can be served through alternative or other means. The second notable exception between NHI and the medical aid schemes are the weight irrespective of their socioeconomic status. Under the medical aid system, even the selected privileged few are stratified according to their economic status. The more senior the job you do, the more you earn and the better quality of health services you get. The more junior your job status, the lesser you earn, the lesser the quality of health service you get. We can no longer allow this state of affairs. It's a flagrant disregard of our Constitution because the Constitution does not recognize economic status in the provision of health services. It is also a flagrant disregard of the Constitution because under medical aid scheme, healthcare is a condition of service for most of the people rather than a right. Contrary to naysayers, the NHI is the one which is in line with the Constitution because it puts healthcare of all South Africans on an equal footing, regardless of their economic status. That's why United Nations use the word universal, because nobody should be left behind. This year, we are at the end of the 5 years, which we regard as a preparatory phase for NHI. Time and again, reports have emerged, especially in the media, that nothing has happened in the pilot districts. Our 5-year preparatory phase was guided by Section 2 of the NHI white paper, which states that NHI represents a substantial policy shift that will necessitate a massive reorganization of the healthcare system, both public and private. In this massive reorganization of the healthcare system, we did what is commonly known as piloting to try and figure out and learn how the healthcare system can be massively reorganized based on the values of justice, fairness, and social solidarity. The time is now to provide a short report about this reorganization. I'll start with infrastructure. Within the 10 pilot districts, we have completed building 34 new and replacement clinics, and we are busy with 48 others. This will give us a total of 82 new and replacement clinics. Outside the 10 pilot districts, we have also just completed 96 clinics and are still busy with 132 to give a total of 228 new and replacement clinics. Once all are completed, we'll be having a total of 310 new and replacement clinics. In the same period, within the pilot districts, we have completed the refurbishment of 154 clinics and are still busy with 192. This will give a total of 346 clinics. As you can see, and outside the pilot district, we have completed refurbishing 135 clinics and are busy with 220. When I add these figures together, it gives a grand total of 701 clinics, new and refurbished, within the last 5 years in the preparation of NHI. This piloting started in 2012. We have also separately put up consulting rooms, 142 of them in the pilot and 21 outside the pilot, 163. Within this preparatory phase, Honorable Chairperson, because I did not mention for the sake of time the nursing colleges refurbished, the hospitals, the new ones, but the total amount of money of putting up this infrastructure was 40,342,973,108 rand just on infrastructure. And in the same period, we spent 1,706,562,156 rand on equipment within this preparatory phase. The second area is access to medicine. You are aware that we've been having problems with what is called drug stock outs. We initiated three initiatives to deal with this matter. The first one is SVS, or Stock Visibility System, whereby each and every clinic has been given a special phone because we're working together with Vodacom Foundation, with a special application where they code, where they scan the code on the back of packages of medicines or bottles. And when they do so, it reports to us immediately in Pretoria, in the central tower. I'm proud to announce that 3,163 clinics have got this SVS, and 658 of them are in the NHI pilot. We did this project, as I said, with the Vodacom Foundation. The second one is what we call RX Solution, and other electronic stock management system. This system is installed in 80% of our 10 central hospitals, 94 of our 18 provincial tertiary hospitals, 83 of our 47 regional hospitals, and 71% of our 254 district hospitals. The system works by reporting stock levels electronically from each of these hospitals to the central tower in Pretoria. If the stock levels are low, it automatically sends in an order. With SVS, Chairperson, we have improved the stocking of ARVs from 69% to 92%, TB medication from 65% to 88%, and vaccination from 64% to 94%. The other system is the central chronic medication, whereby patients who are stable no longer report at our clinics, but they pick up their medicines at 401 pickup points all over the country. 1.2 million. You can clap harder, please. It's not a thing. Yes. 1,300,000 patients are on this system and still counting. Record management system. Honorable Speaker, pre or post-apartheid, South Africa has never had a patient information system that allows us to follow a patient from one facility to the other. This means that one patient can visit as many facilities as they like on any one day to collect medicines and receive civil services without us knowing, because there's no system to detect it. Working with CSIR, the Department of Science and Technology and Home Affairs, I'm happy to announce that in our preparatory period, we have come up with what is called a unique patient identifier. As of the 10th of May, that means by Friday last week, there were 1,859 clinics, 705 of them in the NHI pilots, which are on this system. And I can report to you now, as I'm standing here, that 6,355,759 South Africans are now registered on this system. We are registering people in the 1,859 facilities at the rate of 80,000 to 100,000 a day. Honorable members, the unique patient identifier is linked to your ID in Home Affairs and is a cradle to the grave number. This means as soon as you register, you keep it until you die. If a newborn registers today, that is their number for the rest of their life, regardless of how long they are going to live. Each South African is going to have to register on this system. You can register today if you visit any one of these 1,800 facilities. It will take you 5 minutes to register. But when you come back to get your file, it will take you only 45 seconds to get your file, so that you no longer have to wait for many hours. The 6 million South Africans are already enjoying this service, as I've mentioned. And don't be in a hurry. It's going to reach all the facilities and you'll register. But I want to tell you that this system is preparing for NHI, and we are at 6 million, will one day reach 55 million, and me and you still have to register. Honorable Speaker, one of the recommendations of the Ombudsperson's report on the Life is domain reads as follows, and I quote, "The development of information system with patient registers and total data by which to make evidence-based decisions, monitor and evaluate health delivery must be a priority for Gauteng Department of Health. This recommendation is strongly endorsed by Stats SA. If the Ombuds was to conduct this investigation in any other province other than Gauteng, he will have made the same remark. But I can tell you today, if he goes to one of the 8,855 facilities and investigate the 6 million people as registered, he would make this remark, because he'll get the data he's looking for. This was a massive in this massive reorganization system, Chairperson, we have also completed screening 3.2 million school kids for physical barriers to learning. That's eyesight, hearing, speech, and oral hygiene. And I can report to you today, out of the 3.2 million school kids who have been screened, 504,000 of them have got problems. 8,881, they need a speech therapist. 34,094 have got hearing problems, they need audiologists. 119,340, they've got eyesight problems. They need either an optometrist, ophthalmologist, or maybe spectacles. 337,697 have oral health problems. They need a dentist, dental therapist, or oral hygienist. I do not have to point how these problems affect their studies. In putting up solutions to the problem, as I've just stated, I wish to first quote from the budget speech read by the Minister of Finance in February this year, and I quote, "The service package financed by NHI Fund will be progressively expanded. In setting up the fund, we'll look at various funding options, including possible adjustments to the tax credit on medical scheme contributions. Full details will be provided in the adjustment budget in October this year and in the course of legislative program." Honorable Speaker, the tax credit mentioned in that budget speech in February amounts to 20 billion rand. It's 20 billion rand annually. That leaves the fiscus through SARS to the pockets of people simply because they are on medical aid schemes. It is money paid back to the rich, like sending back coal to Newcastle when your neighbor can not even make a simple fire to cook their food. How do we as public representatives, as honorable members for that matter, justify this type of thing happening in the country under our watch? As honorable members, members of this House, we are beneficiaries of this 20 billion. I'm one of them, you are one of them. This is the worst form of social injustice committed in the name of the cream of South African society, with our full participation. Therefore, Honorable Speaker, we believe the time to change this has arrived, to move towards the economic equality declared by Oliver Tambo. We are proposing then that the first step towards implementation of NHI is to pick up those people who are not on medical aid scheme and provide them services from this 20 billion rand, and that's what we are negotiating with Treasury. Please note, this 20 billion is tax credits only. I'm not yet mentioning the 26.7 billion, which is a subsidy for each person who's on medical aids. Honorable members here included, by the way. We have, as I said, we have identified the school kids. If we get that money when we establish NHI Fund, we will help the 500,000 school kids. We will help with free antenatal care 1.8 million women who fall pregnant every year to do 8 antenatal visits and deliver a normal baby. We'll also be able to do breast and cervical cancer screening and treatment. We'll be able to provide better services for mental health, screening and subsequent services. We'll help the elderly with assistive devices like spectacles, hearing aids, and wheelchairs. We also, Honorable Chairperson, have got a backlog of 270,000 elderly people who are blind because of cataract. With this money, we can do 90,000 a year over the next 3 years so that they will have their sight again. Lastly, we'll be able to provide assistive devices to people living with disabilities. This, to us, is the beginning of revolutionizing the healthcare system. I do hear time and again, Honorable Chairperson, that I'm in the business of watering down NHI and diluting it through multi-payer system. It's actually said that I'm handing over NHI to private hands and betraying voters. These statements are usually issued by our labor partners in COSATU. I tried to conduct them this afternoon because I saw such a statement just 30 minutes ago. Unfortunately, I could not conduct them. I have to clarify the matter here. I did not want to clarify it like this because I wanted to talk to them directly. There's nothing in our policy, not in any of our policy document, that says this type of things that are being said about me. I'll never sell NHI. I know what NHI is all about, and I'm prepared to defend it with my life if that becomes necessary. Honorable members, the nation is still mourning about the terrible events that took place at Life is Demanding. I want to take just the remaining 2 minutes of my speech to give you a report. There were 8 recommendations in that report, and I want to tell you that we have established a project. People are being charged. Recommendations number 8 about SAPS and forensic investigators. I can confirm that SAPS has started investigating long ago. Yesterday, The NPA asked for all the files so that they must start preparing for inquest. Inquest that will be conducted by a magistrate in each and every death, so that at the end, they must decide who to charge and who to prosecute. And these files are being prepared, they will be given to them tomorrow. The South African Human Rights Commission, I wrote them in February. They've started the investigation of human rights abuses. Appropriate legal action for NGOs, I can report that, as I said, SAPS is investigating this matter. And deregistration of any NGOs. There were 27 NGOs all in all. We have relocated patients out of 20 NGOs. The other 7, we haven't relocated everybody. Only Life is the Many people. Because these other 7, we did not relocate their patients because families have refused. And some patients were agitated, they refused to get into the ambulance. 14 of the NGOs have been closed down. Of the 20 where we removed patients, 6 remain open because they are doing other business other than Life is the Many patients, but Life is the Many patients are gone. But we couldn't close them for the other business because that's not what the Umbat said. Recommendation number 5 on the minister, review licensing regulations. I've already done so, and it will be gazetted sometimes on the 19th of May. The relocations of patients, 391 went to Selby Hospital, 398 back to Life is the Many, 461 to Vexcopy, Sterkfontein, Cullinan, and general hospitals, and 9 patients where patients have been admitted. As I've mentioned before, the patients who could not be moved who are representing those families I've mentioned are 19 patients, and their family members have actually signed forms, RHT forms, a form which you sign when you refuse hospital admission. And recommendation 15 and 16 are work in progress. Recommendation 17, where the Ombudsman said we must have an alternate dispute resolution mechanism.
Honorable Minister, you have 1 minute left.
Yes, the team that consists even of family members, some of whom are here today, have agreed with us. A very prominent retired judge has been appointed to do this and will make announcement once certain processes are undertaken. I have also appointed a 3-person tribunal, which is chaired by Judge Ngwebe, the retired judge president of Gauteng High Court, for the people who are challenging the ombudsman, the ombudsperson's report, because the act says they can appeal. Yes, we have got 4 appeals. They've exchanged documents. Any day from today, Judge Ngwebe can announce when are the tribunals going to be held for this appeal. Honorable Chairperson, I hereby present to this House the budget of 42,625,723,000 for the 2018 financial year for the adoption by this House. I wish to take this opportunity to thank my colleague, Dr. Joe Patla, the Deputy Minister of Health, the Portfolio Committee led by Honorable Dinjwa, and the health team led by DG, Ms. Precious Matsuso, as well as my colleagues in the provinces, the MECs. Thank you very much.
Thank you, Honorable Minister. The next speaker is the Honorable Dinjwa.
Thank you, Honorable House Chair, the Minister of Health and his deputy, the honorable members of this august House, our guests, the staff of the Department of Health, nabantu boMzansi Afrika ngokuphelele, siyababulisa. The department has tabled its APP and its track plan in front of the committee for 2017-18, 19-20. It has also tabled its mid-term strategic framework. Also, the Office of the Auditor General of South Africa, the Financial Fiscal Commission, and the Stats SA also table their analysis on the strategic plan of the department. The President of the African National Congress, whom we are celebrating 100 years of his life, Oliver Tambo, during his address at the 4th Congress of Frelimo Maputo in 1983, said, open quote, one of the many visions which unite our people is the vision for peace. Peace so that we grow food, peace so that we study, peace so that we build hospitals and schools instead of spending our resources on weapons of destruction and war, close quote. That vision was realized when the country obtained its democracy in 1997. In remembering the life of OR Tambo, President Jacob Zuma, in his 2017 State of the Nation address, has declared this year the year of Oliver Reginald Tambo. It is the year of unity in action by all South Africans as we move South Africa forward. The health sector in this country carries the legacy of a fragmented and unequal system. In addressing this dual health system, where the expenditure and the resources were divided between public services and private health, but 80% of the population relies mainly on public facility. The need for the establishment of the universal health coverage, Honorable Minister, is paramount. Radical economic transformation remains a priority of the ANC government, as it refers to a fundamental change in the structure, system, institutions, and patterns of ownership and control of the economy in favor of the South Africans, especially the poor, majority of whom are Africans and female. It is in that context that our theme for this debate is a healthy nation is a catalyst towards a radical social economic transformation, united in action. In the same breath, the vision of the Minister of Health, as quoted in the document, a healthy nation for South Africans. This further emphasized the importance of achieving universal health coverage by ensuring that people have access to health care services irrespective of their economic status, that will ensure that people are healthy and more productive to contribute towards the economy. In the National Policy Conference of the African National Congress in 2012, it recommended that we improve the health status of South Africans through provision of prevention of illnesses, reduction of burden of disease, promotion of health lifestyle, and improvement of performance in health system. In ensuring that this vision is realized, the National Development Plan 2013 envisages is saying a healthy system that works for everyone and produces positive health outcomes is not out of reach. The purpose of this vote is to provide leadership and coordination of health services to promote the health of all people in South Africa through an accessible, caring, and high-quality health system based on the primary health care. The Department of Health aims for an unqualified audit opinion with no significant emphasis of matters of emphasis for 2017-18, and it is in that context that they want to assist 5 provinces to achieve that. And we hope that their program with the Chartered Accountant, their program with South African Institute of Chartered Accountant will ensure improvement in these outcomes for all provinces. Honorable Minister, in terms of the programs of the department, I will just sketch through because there are members that are going to go into detail in terms of what, as the committee, we have seen, we have outlined. We welcome the work streams that have completed their work But we hope that that will be tabled in front of the committee for us to really see and be on board with that. We commend the introduction of the stock feasibility system, which monitors medicines. But as we have conducted our oversight, we are still concerned in some of the areas. But we are comfortable that the department has managed to enroll millions of our people in the Central Chronic Medicine Dispensation and Distribution. This program, we are confident that it's reducing the need for patients to wait long queues in health facilities for the collection of their medicines. We are comfortable and we're happy to say to the people of South Africa as the Portfolio Committee that we welcome the introduction of the new TB drug. This will encourage TB patients not to default. But however, we are saying the department must increase its budget in this program. We also welcome the test and treat strategy, because we do think that this will also encourage in ensuring that we have got a healthy community, a healthy citizens, healthy people of South Africa that are going to contribute in the economy of this country. We welcome the introduction of the youth program. We think that this will also assist in ensuring that it takes away the stereotype in our people, especially the communities that don't want to talk about health, youth health, but in particular the sexual reproduction. But we have identified that the department is very weak in the area of malnutrition. We think that you are going to improve. Members will talk more about this. The engineering of primary health care is an important step in envisaging universal health coverage. But we are also concerned, Honorable Minister, about the state in some of our districts, the system, the staffing, and how then work is then being conducted in that. And we hope that that will also be looked into and be monitored. In terms of the environmental health management, health wastage management, we are saying, Honorable Minister, the talk between the two departments, the Department of Health and the Department of Environmental Affairs, they must speedily sit together and address this, because health waste management, if it is not managed properly, it is hazardous to our country and to our people. And therefore, the managing of health waste in the institution, and when it goes out to be then addressed by the Department of Environmental Affairs, that is going to be very important. We are worried, Honorable Minister, we are concerned as the committee about the shortage of staff. You have spoken here about youth programs at schools, but we have identified that in this area, the Department of Health is very weak in the training of these disciplines, but also the employment of the allied workers. Because if then you are not focusing on that, we think that you are, as much as there is work that is being done, we think that you are not then going to achieve the major goals that you want to in assisting the national department, the basic education, because we think that as you have introduced this program of school health, and we want to commend and encourage, but we say in that of ensuring that every learner passes, because that of not of only looking into the end results in grade 12, we think that the program that you have introduced of looking at a learner from an early childhood development up to that is very important. But we want to make an emphasis. Please look into ensuring that allied professionals are then being employed. In terms of our entities, we commend our entities that when we have told them about their weakness in terms of transformation, in this time around, they have managed to have, to have learnership programs. That is the Office of the Health Standard Compliance. But we are very concerned about that. We are very concerned about the acting position of the CEO. We think that it has been acting for some time. Also, we encourage the Council of Medical Research Council for ensuring for them to also have learnership programs. And we do think that we have encouraged the Council of Medical Scheme to improve its awareness so that people understand what is entailed in the medical aids and what is it, how then they are going, what then becomes the role of the Council of Medical Schemes in ensuring that it empowers our people. We commend the CCOD for the work that it has done, knowing that there are still challenges, but we think that it has also, it includes the stakeholders in that. That is very important. We have made an emphasis, we commend the work that is being done by the Medical Research Council of South Africa, but we want, Minister, that the department monitor this. We feel that they are very weak in the research around Africa, and we don't think that we must then, the research must only be around the other countries, and we think that the Professor Gray is doing a good work. And but the emphasis is that it then must be around the research in Africa. Before we conclude, we think that in terms of the unfortunate situation of the life at ECD Bank, we want to make an emphasis that there must be a collaboration between the departments that are dealing with the issues of mental illnesses, social development, because the area of frail patients, and the Department of Health, the Department of SAPS, because of the drug situation. In conclusion, the realization of the radical socio-economic transformation is largely dependent on the healthy nation that will result in a health workforce. That is why we commend the unions, as much as there are those problems in the affiliates of COSATU, but I am reliably informed that there are affiliates that have got health centers in workplaces, and will encourage the Department of Health to look into those, which is SAGTU, South African Democratic Teachers Union in KZN, and Textile here in the Western Cape. The health objectives of the department are thus an essential tool of achieving this transformation. In the spirit of our Tambo, we encourage the committee, irrespective of political affiliation, to unite as we will be conducting our oversight in ensuring that the health system is improving, because health matters don't have any political affiliation. I will say that every day, Honorable Minister. TB has got no political affiliation. HIV and AIDS have got no political affiliation. And therefore, as this portfolio committee of health, it is important that we unite. Where we think that there are differences, we address those amicably, not for the benefit and for the politics.
Honourable Member, your time is now expired.
The African National Congress support budget 16.
Thank you, Honourable Member. The next speaker is the Honourable James.
Chair, if I may, as a personal comment, say that I'm deeply disappointed in the comments attributed to the Honourable Minister, that he will push through the NHI even if there are objections. With an outright majority in Parliament, of course he can. But that is not the language or approach of a Democrat. Parliament is a platform of public deliberation. Here we appeal to reason, to rationality, and to evidence in order to persuade others. Yours, Minister, is the language of an autocrat, and I do not admire it. It is not wise in any case to use a sledgehammer against trade unions. Chair, South Africa lives with the world's highest epidemic of HIV/AIDS, a preventable disease that brought widespread death, extraordinary misery, and great hardship to our people. Close to half of the millions of orphan South African children lost their parents to HIV/AIDS. The reason for this calamity is not the work of the medical professionals, but it is the failure of political and moral leadership to promote responsible safe-sex practices under circumstances where a vaccine was, still is, and is likely to be unavailable for a long time. It did not have to be like this. F.W. de Klerk's last apartheid government did not know what they were facing. A University of Cape Town group led by Mampila Rampele went to see Nelson Mandela in 1999 to persuade him to declare a national emergency. He urged the then Minister of Health, Nkosazana Zuma, Dlamini Zuma, to declare a health emergency, but she failed to do so. It was Barbara Hogan and the Honorable Aaron Motsoaledi who led South Africa out of what some have described as quiet genocide, for which no one to date has been held accountable. Dlamini Zuma has a lot of explaining to do. On her watch, in an act of nepotism, a 14 million rand contract was awarded to one Mbangeni Ngema, a good friend, as she called him, to produce a sequel to the musical Sarafina. Dlamini Zuma was also criticized for supporting Virodin, a quack remedy, let me tell you, for HIV/AIDS, which was in fact a toxic industrial solvent rejected by the health science community as ineffective. I was personally present at the meeting with Nelson Mandela when he said that he will call on Dlamini Zuma to declare HIV/AIDS an emergency, and he, as we all know, always kept his word, but she did nothing. May her soul rest in peace, but Manto Shabalala Msivang is no longer with us, and we will not speak ill of the dead. Thabo Mbeki, on the other hand, whose stubborn anti-science denialism is the reason why Minister Motsoaledi inherited a budget that's organized around the health implications of HIV/AIDS, and it stands in the way of implementing a much-needed plan for health system strengthening. I recall this history.
On a point of order, Chair, I'm sorry to interject our speaker. Can you please protect our speaker? We can't hear.
It's okay, he's protected. Honorable members,
I recall this
Honorable
history.
Honorable James, can I just address this point? Honorable members, interjections are allowed. However, we do not allow running interjections that can potentially disrupt the speaker. You may continue, Honorable Member. Order, Honorable Member. Honorable members, if you do not agree with the content of the speech, that is the member's view. That is his view, and he must be allowed to raise his views. Order. Continue, Honorable Member.
It's the political thuggery of the ANC in this House, I'll let you know. I recall this history, if you can listen, members, because it is important that honorable members understand that a health budget should not be designed simply for a crisis. It should be designed to constantly address multiple disease and illness risks. The World Health Organization identified the 6 building blocks of a health system as follows. First, good health services are those which deliver effective, safe, quality personal and non-personal health interventions to those that need them. Secondly, a well-performing workforce is one that works in ways that are responsive, fair and efficient to achieve the best outcomes possible. Third, a well-functioning health information system is one that ensures the use of reliable and timely information on health determinants, health systems performance, and health states. Fourth, a well-functioning health system ensures equitable access to essential medical products, to vaccines, and to technology of assured quality. A good health financing system raises adequate funds for health in ways that ensure that people can use needed services and are protected from financial catastrophe or impoverishment associated with having to pay for them. And finally, leadership in government involves ensuring strategic policy frameworks exist and are combined with effective oversight, regulation, and accountability. Saving lives is, of course, a moral obligation, and we will therefore spend, as we must, a monumental amount of money on HIV/AIDS until the epidemic burns out. The Honourable Minister Motsoaledi has distinguished himself as a minister in delivering on this moral obligation, something one cannot say for most of the rest of the ANC cabinet, and certainly not for President Zuma, who is everything but moral. But HIV/AIDS will not burn out, colleagues, unless we stop the new infections, especially among young women. I do not believe that we are aggressive enough with our efforts, and I challenge the minister to tell us what he plans in this respect. He said nothing about it today. To deal with the ongoing HIV/AIDS and TB crisis and strengthen at the same time our health system will require both more money and better management. The Honourable Minister is focused on the money side. In fact, he almost spent all his speech speaking about the money for NHI. He wants to compel those on medical aid or health insurance to pay their monthly subscriptions to his NHI in return for services over which they have no control. He would like to have access to the medical aid reserves that runs into billions, eliminate the medical aid tax credits, and block the universal subsidy to middle and income earners. And let me say, some of the money should go over in an act of health justice. But it is both illegal and it is unconstitutional to raid the funds as he is proposing. And we will challenge him on that. But let me say, what the minister should be focusing on more with greater emphasis is on good governance and good management. He is running out of medical doctors and he's running out of nurses. The average quality of our hospitals is shocking. We have enough clinics in our country, but can only staff half of them. Bad governance and poor management is why the Esidimeni tragedy happened. In any health system worthy of its name, an unusual pattern of death would be evident immediately and provoke an immediate response. The Gauteng province may be the principal frontline offender, but the ANC governance failures run wider and deeper, which is why the DA still believes that it is of the greatest importance that President Zuma appoint a judicial inquiry into this saga. In South Africa, colleagues, private and public health systems exist in parallel. The public system serves the vast majority of the population, but it is chronically mismanaged and understaffed. The better of 20% of our population use the private system and are much better served. There are no objective measures against which we can rate our standing against these goals, because our Office of Health Standards Compliance and other research agencies are not geared to collect data on the scale. Indeed, as we pointed out in our health plan, there is no system in place to assess the performance of the public or private healthcare sectors, which means that policymakers and the Honourable Motsoaledi are flying blind. What we do know is that for the money we put in, the health outcomes are deeply disappointing, and we don't spend small change. The consolidated health expenditure for health at all levels of government was 168 billion rand, the largest after education, which stands at 297 billion rand, or 11% of our 1.46 trillion national expenditure in the 2016-27 financial year. This is impressive by any standard. But our health outcomes, though improving, are dreadful. Experts usually use maternal mortality figures as a proxy indicator for the quality of a health system measured by its outcomes, and ours is embarrassing for a country at our stage of development. According to the Department of Health's own report, Saving Mothers, our institutional maternal mortality rate is declining, but it is still excessively high at 141 deaths per 100,000 live births. The Free State does the worst at 203 deaths, and the Western Cape does the best at 66 deaths. But even this is simply not good enough. It should be under 50 per 100,000 live births, which was our millennial development goal we have set for ourselves but missed by far. The consequence of these trends is that the budget before Parliament is not designed to strengthen our health system, but to deal with the HIV/AIDS crisis and its consequences. It is therefore simply reactive. Of the 42.3 0.63 billion set aside for the national ministry, 15.75 billion is for HIV/AIDS, 27.5 million for TB, and a mere 18 million for maternal and child health, or, in other words, 37% of what the Honourable Minister has to spend. There is no measure of the real cost to provinces of treating HIV/AIDS patients in all of their clinical settings, but it must be considerable. When in national government, the DA will introduce strategic reforms to extend the coverage provided by medical aid and health insurance to serve 65% of the population, that is, 65% of our population actually have jobs, which will take the pressure from and create the opportunity to upgrade the public health sector to meet WHO standards of care for those without jobs in a mixed health economy. As an example of the DA's commitment to improving healthcare, where we govern at metro level in the city of Johannesburg, for instance, we have ensured that 6 clinics are now open in the evenings and on the weekends to allow more people access to healthcare. In the new budget, the DA have proposed that millions be allocated to ensure that all other clinics in the city are also able to extend their hours. The DA believes that every part of our health system should be modernized, but priority must be given to building a highly effective primary healthcare system that responds to the needs of all those vulnerable to illness. And let me end by saying that congratulations are due to the loyal civil servants in the Department of Health and the various health entities for soldiering on, while this President Zuma and some of his colleagues tear down the house that Nelson Mandela and some of his colleagues built. Among the health entities, I was particularly taken by the extraordinary work of the Medical Research Council, the National Institute of Communicable Diseases, and the Compensation Commissioner for Occupational Diseases, who all deserve, in my view, a performance-based budget. But what there is in this budget is wholly inadequate. Let me end off also by saying that what the National Health Insurance System is a new financing system for healthcare. It is not a new management system for healthcare. It is not a new governance system for healthcare. It's a new financing system for healthcare. And the fact is that it will result in what's known as national purchasing. A single payer on a national level will buy healthcare for the nation. It requires a bureaucracy at a national level that is highly efficient, that is highly effective, that is able to pay for people's needs in the healthcare system on time. It will require a staff that would be monumental. In fact, it will require a staff that is twice as large of what anything Treasury can put together. And this government does not have a good record of having an efficient bureaucracy on a national level. I can name one or two. Treasury is one example, but for the rest, it is incapable of running anything on a national level in an effective and an honest way. And the fact is that if you leave the healthcare needs of all South Africans to the ability of this national bureaucracy to pay
Honourable
on time,
Member, your time is now expired.
pay on time, it will be ineffective. I thank you.
Thank you. The next speaker is the Honourable Tembe Kwayo.
Honorable Chairperson, the Economic Freedom Fighters reject budget vote 16 on the Department of Health. The EFF, can I be protected? The EFF aspires for an accessible, high-performing public health system that ameliorates health disparities and provides quality health care, bolstered by multi-sectoral mobilization under adept management, leadership, and governance. Unfortunately, South Africa is very far from achieving these ideals. Firstly, public health sector is littered with examples of poor leadership, neglect of public health care sector, leading to preventable deaths among the poorest and most vulnerable of our people. The South African Health Review
published by the Health System Trust in November 2016, identified 3 key fault lines in implementation underpin the relatively poor performance of our health system and are impeding realization of improved health for the nation. These faultiness are tolerance of ineptitude and failures in leadership, management and governance, a district health system that does not adequately drive the delivery of primary health care, and the unsolved health workforce crisis. This constitutes a conjoint threat to the feasibility of national health insurance. Secondly, Mr. Chairperson, good quality health care remains inaccessible to the vast majority of people who do not have access to medical aid. Only 17.4% of the population is medically covered, and that is just 9.4 million people, leaving 45 million people without cover. Further, only 10.5% of Black African people are covered by private medical insurance, compared to 72.7% of white people. To highlight the depth of the problem, there are 25 state doctors and 92 private sector doctors per 100,000 people in South Africa. This, therefore, means that if you have money and can afford private medical care, you are more likely to get help than if you are poor, Black, and have no other option but to use the public health system. Whilst this paints a very bleak future picture, the South African Department of Health continues as if it's business as usual. It is also for this reason that the implementation of the national health insurance is so critical. To this day, it is not clear when NHI will be implemented. It is not clear where the budget for the implementation of NHI will come from. But more seriously, under the conditions we have just explained, it will be difficult to implement the national health insurance. There needs to be a massive systematic focus on refurbishing public hospitals, on ensuring that these hospitals are resources with good quality doctors and nurses, with properly qualified management that can respond to issues faced by our people on the ground. Many rural hospitals have just one or no permanent doctors. Between 70% and 80% of doctors also prefer not to work for the state, but the main reason for this is not poor pay, but poor working conditions. Other reasons include a lack of equipment and medical provisions, a heavy workload, and insufficient protections against HIV and tuberculosis infections. This is a crisis, our minister. And despite some of the commendable work you have personally done, the problems relating to healthcare in this country are structural and require the fundamental that you must lead a process to restructure healthcare in this country. That must entail the dismantling of the divide between the public and the private healthcare sector. The country must have one healthcare system that takes care of all South Africans. For these reasons, therefore, our chairperson, we as EFF reject budget vote 16. Thank you.
Thank you, Honourable Member. The next speaker is the Honourable Nkomo.
Thank you very much, Honorable Chairperson. This portfolio is close to our hearts and that of our leader, His Excellency Prince Buthelezi MP. A nation, Chairperson, without strong and resilient health is a nation that will be unable to achieve any of the myriad of other goals it sets itself. Accessible, essential and affordable health services are key to this objective, with the promotion of health, its prevention, treatment, rehabilitation, and palliative care, all making up its foundational pillar. Whilst our nation, Chairperson, still grapples and tries to come to terms with the tragic and unnecessary death of more or less 100 mentally ill patients in Gauteng, we trust that the department has made every effort to ensure that such a tragedy never occurs again, and that those responsible will bear the full might of our law and in respect of their reckless, negligent, and mismanagement of patients' protocol. This will forever be a departmental disgrace and damning indictment on the minister, who must assume full responsibility. All the 27 NGOs in this matter were found to be operating under invalid licenses. How the Gauteng Department of Health saw fit to transfer these patients from licensed to unlicensed facilities beggars all belief and raise more questions than answers. We trust that a full investigation and report on the matter will be completed post-haste and released to the public, because the people of South Africa would like to know what actually happened. Honorable Chair, we are losing the fight against cancer as well. Cancer is now responsible for more deaths every year than AIDS, tuberculosis, and malaria combined. It is a dread disease that demands our fullest attention. The IFP, through our late comrade and member of Parliament, Dr. Mario Gaspari Oriane Ambrosini, introduced the Medical Innovation Bill, BMP1, in 2014, which, among others, sought to create the space and platform necessary for research into interactive and alternate medicine to take place. It seeks to innovate in order to possibly find cures where Western medicine has failed to find remedy. The bill, which has been reintroduced by the IFP Chief Whip, the Honorable Naren Singh, has been embraced by the Portfolio Committee of Health because of its forward-thinking ideas and potential benefits for all South Africans. It still remains before the Portfolio Committee of Health. At the last meeting, which was on the 23rd of November 2016, it was agreed by members of the Portfolio Committee that the Department of Health and the IFP, including the Department of Health itself, that the bill be held in abeyance pending the finalization by the MCC regulation. This is quite important to us as the IFP, because we need to look at the growth and how this bill actually moves forward. We also take note
Thank
of
you
the
so
Medical
much,
Control
Honourable
Council
Member.
issues.
Your time has expired.
Thank you. The IFP supports this budget vote. Thank you, Madam.
Thank you very much, Honourable Member. Honourable Sheikh Imam.
Thank you, Honorable Chairperson, Minister, Deputy Minister, Chairperson of the Health Committee, the DG and her team. At the very outset, let me advise the National Freedom Party supports the budget tabled here today. Honorable Chairperson, good quality healthcare is the fundamental right of every citizen in this country, including but not limited to foreign nationals presently residing in the Republic of South Africa. The National Freedom Party supports this budget with reservations, Honorable Chairperson. And one of the reasons for this is that every single province that did a presentation to the Appropriation and Department of Health have all admitted that the funding available for healthcare in South Africa is totally unreasonable and unacceptable and not enough. Now, remember, Honorable Chairperson, South Africa for 23 years has been, and I must commend the Minister of Health. I think the Minister of Health and his team are doing the very best in South Africa in being able to try to take healthcare to the length and breadth of South Africa. And that is not always appreciated because people judge you on what you don't do rather than what you do. And there's been a lot of success in South Africa in this regard. And let's be honest, it's with limited budget, with limited resources. Let's not forget what we have received, what we've, in this particular country after apartheid, after we have suffered for hundreds of years by the apartheid regime, and now having to come and being able to change from one extreme to the other extreme. Let me add, Honorable Chairperson, every single province in the country has challenges in terms of healthcare, and there's no exception. Ask me because I've spent a lot of time even in the Western Cape, and I have seen the conditions and how our people are served at the hospitals and the clinic. So what should really happen here, Chairperson, is that we political parties to stop grandstanding. What we should do is come together, united, so that we can create a better and a healthy life for our people. Now, I've heard people complain of what happened 10 years ago, 15 years ago, and 20 years ago. Are we going to continue complaining, or are we going to come together so that we can work together? And if we've got ideas that might work, let's bring it to the department so that we can work together in creating a better quality of life for the people. But what is very clear in South African society is that we don't want the government, we don't want our people to have a better quality of life.
Can you take a seat a little bit?
Chair.
Yes, Honorable.
Chair, if the speaker can relax, he's shouting our eardrums. It's not good.
Honorable member,
I know ANC will give him something, but not in this rate,
Not a
please.
point of order, Honorable member. You may continue, Honorable.
Honorable
Thank you,
Speaker, may
Chairperson.
I address you?
Honorable Chairperson,
May I
let me
address
also
you, madam?
welcome the introduction of the health tax
May
to
I
fight
address you?
diabetes, hypertension, and other diseases. This must be welcomed.
May I
In
address
order
you,
to
please?
succeed, the department
Thank
must
you.
make more attention.
I apologize, Honorable.
I think
yes,
actually
Honorable Gomo.
some of us are hearing him the wrong way. I think he needs to speak louder in
What
order
point
for
of-
us to
what-
even
what-
hear
what-
more.
what is that point
Please,
you're
can we
saying?
appeal that he speaks louder?
But again, Honorable Gomo, that's not a point of order, please. May you continue,
I
Honorable
think,
Imam.
I think
Please,
more than the
Honorable
mic,
member,
South
let us
Africa
not
needs to
interject
know
like that.
what opposition politics in South Africa is not about the people, it's about power, it's
Yeah,
about
Chair.
control, it's about grandstanding,
speaking
and
the
that's why
honest-
maybe I'm allowed to
honest
let them
truth.
know. Honorable Chairperson, we call on the department to also pay more attention to the escalating food businesses with the highest sugar content that are being formed regularly in the country. These businesses, including retail outlets, only interest appears to be capitalist nature, creating wealth at the expense of our people. We call on the department to introduce stringent conditions
Thank
and
you very
inspections
much,
to ensure that
Honorable
these
Imam.
visits
Your
comply.
time is exhausted.
The National Freedom Party supports this budget vote. Thank you.
Thank you. Thank you very much, Honorable Member. Now I call upon the Deputy Minister of Health to ascend the podium.
Thank you very much, Honorable Chairperson, Honorable Minister of Health, Dr. Aaron Motsoaledi, Ministers and Deputy Ministers present, Honorable Chairperson of the Portfolio Committee of Health, Honorable Dunjwa, Honorable members of the National Assembly, the DG and managers from the department, distinguished guests, ladies and gentlemen. Honorable Chair, thank you for this opportunity to participate in this budget vote for the Department of Health. I also want to follow my colleagues and comrades in dedicating my contribution to the memory of one of our outstanding leaders of our struggle for freedom and democracy, Comrade President Oliver Reginald Tambo, President of the ANC from 1967 to 1991, who would have been 100 years today had he lived up to this year. President O.R. Tambo stood for everything good in our society. He stood for selfless service. He stood for humility, for integrity, for honesty, always putting the people first. He was a scholar of science, a teacher of mathematics, and also an aspirant priest. In his memory, we must make sure that universal health coverage is implemented as a means to improve the quality of life of all our people. According to the 2015 report by Stats SA on causes of death, non-communicable diseases continued their rise in ranking amongst the top 10 causes of death, with diabetes moving from third in 2014 to second in 2015. Non-communicable diseases which contributed to the highest causes of death include diseases of the circulatory system at 17.8%, respiratory system 9.6%, carcinomas 9.1%, and metabolic diseases at just under 7%. Cancer, in terms of the cancers, the latest National Cancer Registry reports show that the top 5 killers amongst men, it's first prostate cancer at just under 19%, carcinoma of the skin at just over 10%, colorectal cancer at about 5%, lung cancer just under 5%, and Kaposi carcinoma at just over 3%. In females, the leading causes of death amongst cancers is CA of the breast, followed by CA of the cervix, CA of the skin, colorectal, and also CA of the uterus. Our strategic plan for prevention and control of NCDs 2013 to 17 is coming to an end. We are therefore starting the process to review the impact and shortcomings so as to inform the new strategy to be launched in 2018. It's, however, quite clear that we need to improve our capacity to work with other role players, including NGOs and private sector organizations, in order to, amongst others, increase awareness in society about NCDs and measures to prevent them, increase access to screening for early detection, maximize access to effective treatment with efficient and affordable means of treatment. Also in this regard, including putting pressure on pharmaceutical companies to reduce prices of life-saving cancer medication. Access to cancer services, to care at all services of all levels of health system needs to be strengthened, and implementation of the policies which you have recently approved to deal with breast and cervical cancer need to be implemented. These policies introduce access to essential treatment and also appropriate technology for screening, including also screening for cervical cancer. South Africa has performed very well in as far as implementation of the HPV vaccine, and we remain one of the leading countries in this regard, with over 1 million girls vaccinated on an annual basis. As we do so, we are aware that with our high burden of disease and injuries, we must prioritize integrated chronic service management model, which will also contribute to sustainability of the ideal clinics. We are looking forward to the implementation of the tax on the sugar-sweetened beverages by the National Treasury, which will help reduce high levels of consumption of sugar. We are in the process of amending also the Tobacco Products Control Act and also a new proposed tobacco bill, which will strengthen regulation for tighter measures for creation of 100% smoke-free public indoor spaces. This will also lead to introduction of standardized plain packaging of tobacco products and also cover the electronic nicotine and non-nicotine delivery systems, which are still out of the loop at this stage. Honorable Chairperson and members, we are pleased that we have joined only a handful of countries in adopting a national policy framework and strategy on palliative care, which is based on the WHA, the World Health Assembly resolution. This creates an enabling framework for the care of patients and families facing life-threatening diseases, improving quality of life while maintaining dignity from time of diagnosis until death. The implementation of the policy will be overseen by a steering committee on palliative care, chaired by Dr. Sibongiseni Dlomo, the MEC for Health of KZN, who is an expert in this field. In the field of malaria, our department set the target of 0.2 malaria cases per 1,000 population at risk, those populations at risk for 2016-17 financial year. 2 of the malaria-affected provinces achieved the target, with Mpumalanga recording an incidence of 0.2. KwaZulu-Natal, very impressive, 0.1 per 1,000 population. The Limpopo province had an increase of 0.6 cases per 1,000 population at risk. The key factors that could have resulted in the increase of cases were weather conditions, climatic conditions in the Southern African region, with the abundance of rain over the last few months. The National Department, in collaboration with the provinces, are responding to the increase in malaria cases by strengthening case management at primary healthcare level, by ensuring adequate stocks of diagnostic tests and treatment, and training in frontline healthcare workers. In addition, malaria prevention is being scaled up through community behavioral change programs and also focal indoor residual spraying. Lastly, the malaria programs have set up screening and treatment mobile facilities close to the transmission hotspots. We are also encouraged to say that the Elimination Aid Initiative, which is a collaboration among 8 countries, Angola, Botswana, Namibia, Mozambique, South Africa, Swaziland, Zambia, and Zimbabwe, is fully operational. We are hoping that this regional initiative will help cap the spread of malaria in the Southern African region. We're also in collaboration with Swaziland and Mozambique in what is called Mosawa, and through which we are doing cross-border management. And the intervention in the areas of KZN and Swaziland recorded the lowest number of malaria cases in Southern Africa for the 26-2017 financial year. This is particularly encouraging. Hence, we will be scaling up our efforts regarding the Mosawa cross-border malaria initiative in the current financial year. The Medical Research Council, thanks to the Honorable Wilmot James, I heard him also singing praises of the MRC. MRC continues to provide invaluable support to our health service system. The Council plans to extend the 3-year Memorandum of Understanding with National Institutes of Health in the US by 2 more years. This is to fund biomedical and behavioral health research in the area of HIV, TB, and also in HIV-associated malignancies, and to build long-term collaboration between service providers and South African universities and other institutions. The collaboration is projected to make a significant impact on HIV and tuberculosis outcomes in South Africa. The Council has launched the 3-year, 30 million Grand Challenges South Africa program on maternal, infant, and neonatal health in collaboration with the Bill and Melinda Gates Foundation to identify innovations in gestational diabetes, perinatal hemorrhage, preeclampsia, and neonatal survival. The Council also collaborates with a number of other research partners, including the Newton Foundation, the British Medical Research Council, GlaxoSmithKline, and Canadian Institutes of Health Research. Coming to the Council for Medical Schemes, the Council for Medical Schemes suffered a major blow early this year when its newly appointed CEO, Dr. Humphrey Zokufa, died suddenly after only about 3 months in office, after a long search for a CEO. We again pass our condolences to his family. The process of finding a new CEO is quite advanced. The Council's principal role is to remains the protection of the rights and benefits of members of medical schemes and their dependents. The Council will advise the Department of Health on future role of medical schemes, Honorable Wilmot James, in a national health insurance context, because it is coming. And investigate any reported, and it will continue to investigate any irregularities in governance and compliance with the law by any of the medical schemes. The Council has improved its turnaround for resolving complaints from scheme beneficiaries and is aiming to make further improvements. Coming to our National Health Laboratory Services, this also remains the main provider for diagnostic and other clinical laboratory services in the public sector. And notwithstanding administrative governance challenges from time to time, it remains a very dependable institution in providing these services. The NHLS will, over the medium term, continue to conduct affordable, sustainable, and high-quality laboratory services. It will focus on national priority programs which were identified by the department in 2010, in making sure that we can, in patient testing, including HIV and associated opportunistic infections such as TB, cryptococcal meningitis, and hepatitis. The organization will also continue to provide training for pathologists and various other professionals. Through the National Institute of Communicable Diseases and the National Institute of Occupational Health, and through its own research program, the NHS will continue to contribute to research and development and provide platform for training for students of pathology. Coming to the recently established South African Health Products Regulatory Authority, as of April 2017, the SAPRA was established as a Schedule 3A public entity responsible for regulation of medicines. These functions are currently performed by the MCC. The transition from MCC to SAPRA will allow it to operate more independently and retain revenue collected from the industry. Over time, SAPRA aims to absorb some of the external evaluators so that it can create more capacity and deal with the backlogs in applications and gradually improve. Once the regulations for medical and diagnostic devices have been gazetted, SAPRA will also regulate the products, also non-medical products, and also hazardous radiation products. We have made a lot of progress in the area of emergency medical services. Regulations which were promulgated have been finalized. These regulations will facilitate standardization of EMS in the country and will be finalized during the course of the year. We'll also finalize regulations relating to mass gatherings so that we can be able to, in advance, plan and deal with possible catastrophes during mass gatherings. We have reviewed regulations relating to forensic pathology in order to meet the needs for relating to non-natural causes. These regulations will be promulgated together with the revised scope of practice guidelines during the course of 2017-2016. We are looking at the plight of forensic pathology officers by establishing a career path for them together with the Health Professions Council. Coming to the Nelson Mandela Fidel Castro Medical Collaboration, Honorable Chairperson and Honorable Members, this medical collaboration program continues to add value to the human resources capacity of our health service. We currently have 427 Cuban doctors deployed mostly in our rural facilities, with only a handful in the Gauteng province. 520 graduates from this program are already in our service over the last 20 years, and in July this year, 53 graduates will graduate in Durban from this South Africa and Cuba medical collaboration. Currently, we have a total of 2,905 students who are in the Cuban-South Africa program, with 76 in the final year of study. An important shake-up to our system will be in July next year, when more than 900 final year students will descend on our shores from this program to come and do their final year here in South Africa. It will be a big jump from the average of 70 final years per year to now 900 in 1 year who will be coming into our system. It does provide a major challenge, and we are working with all our medical schools and also our provincial departments of health in making sure that this number can be accommodated. We're looking at this as a challenge, but also as an opportunity to broaden our training platform in South Africa, also to transform.
Deputy Minister, unfortunately, your time has expired.
Thank you, Honorable Chairperson.
Thank you so much, Deputy Minister. I now call upon Honorable Maisela. Honorable Maisela, can you come to the podium, please? Honorable Maisela, can you use the podium here, please? Yes.
Yes, come and do that, please.
Yeah. Thank you so much.
Thank you.
Can we listen? Can we give Dr. Honorable Maisela an ear, please? Over to you.
Honorable Chair, Honorable Deputy President, Honorable Minister of Health, Honorable Deputy Minister, Honorable colleagues, and honorable guests. We deal with something that is very important to everybody, and that is health. Because a healthy nation is a catalyst towards radical socio-economic transformation and unity in action. A long and healthy life for all South Africans. A healthy mind in a healthy body makes a healthy man, and a healthy man makes a healthy nation, which is a productive nation. The purpose, sorry? Oh yeah, well, man is a generic thing. We don't, I don't, sorry, and a woman. When I say man, I don't differentiate. It's not a gender thing. Okay. Yeah. And to create the wherewithal, okay, which makes it a wherewithal. The purpose of work is to create the wherewithal to keep the body healthy and thus a nation healthy. A nation united in action to create wealth which is equitably shared will achieve a long and healthy life for all in South Africa. We all know that the greatest social cause of ill health is poverty. The government's radical socio-economic transformation is primarily aimed at combating poverty by using the abundant resources we have equitably to fight poverty, and by so doing, remove the greatest driver of ill health. Let me deviate a little bit from what I've written and try to remind fellow South Africans, those who have short memories, that poverty was engineered by the apartheid regime by dispossessing us of our primary means of production, the land. And since we say poverty is the driver of ill health, this is the greatest cause of the plague. I hear people talking about other people causing or not doing anything about HIV/AIDS, which is preventable. Well, they don't tell us how to prevent it. They just say we don't prevent it. Now, you see, our people were brutalized, they were oppressed, they were exploited, and they were treated as non-human by the brutal regime of apartheid. Some of our people are still the progenies of that particular system. OR taught us unity, and love of the people. And the Freedom Charter also teaches us to love our people. We are all South Africans. We have one South Africa. We don't have any other South Africa. And the Freedom Charter says South Africa belongs to all who live in it, black and white. Okay? That no government can claim authority unless it's based on the will of all the people. You see, when Macmillan came here in 1960, he talked about the wind of change that were blowing from the north to the south. And in 1964, Verwoerd proclaimed the Western Cape a safe haven for whites, so that when the wind of change are pressing them into the sea, they can retreat in order to go back somewhere. But we don't talk about that. That is not what we are all about. We are here to build a nation, and a nation that is healthy, a nation that is united, the nation of South Africa, which can be the greatest nation on earth. But some people still hanker for the good old days when people were treated as non-people. But we are not there. We are somewhere.
Point of order, Chair.
Honorable
I'm
Maisela.
rising on
Honorable
Rule
Maisela.
68.
Can you
Chair.
pose a little bit? Honorable Member, what's
I'm rising on Rule 68, irrelevance of the debate. So can we ask the honorable member to stick to the budget vote of Department of
Honorable
Health?
member, it's so unfortunate that
Unfortunately, I
sometimes
can't hear you
the
very
point
well.
of relevance is very subjective.
What did she say?
Let us not get into that one, honorable member. You may continue, honorable Maisel. Continue.
Thank you, Chair. The 1914 Manifesto of the ruling party and the 53rd National Conference call for a decisive action to effect economic transformation and democratization of the country. The second phase of our transition from apartheid colonialism to the National Democratic Society would be characterized by united action by all South Africans to eradicate poverty, create full employment, and reduce inequality. I don't think anybody can fault that. All right? Health is not just a social issue. The social determinants of the social determinant of ill health and lifestyle is the major goal and is to reduce the disease burden to a manageable level. Human capacity is key to achieve this. Communicable diseases like HIV, AIDS, and TB are a scourge for everybody, and they know no color. South Africa is experiencing a generalized HIV and TB epidemic. It continues to be home to the world's largest number of people living with HIV, and as a number one killer, HIV has now been reduced to number 5. It has been taken over by TB. The number one spot is taken over by TB. And the reason is simple. This is because almost everybody who is diagnosed with HIV/AIDS infection gets antiretroviral treatment regardless of the status of the disease. People live longer and useful and active lives. More than 6.8 people live with HIV and get treatment in South Africa. Screening and treatment as well as preventative methods are intensified and readily available for free in government facilities. The problem of stigmatization is greatly reduced, and people living with HIV/AIDS are now, by and large, acceptable in society. The evolution of HIV/AIDS prevalence among women presenting for antenatal care in the public sector has been routinely measured since 1990 and has stabilized around 29%. Since 2004, HIV mortality incidence estimates and the number of people living with HIV, that is, in 2016, there were 119,861 births, and 539,714 deaths, and the number of HIV-related deaths, 150,759, which is 27.9%, and AIDS death, that is from Stats South Africa, 2016. TB management. TB control management sub-program is responsible for
Honorable
the
member,
coordination
you're
and
left with
management.
1 minute. 1 minute to go.
Okay. 1 minute left. Okay. With the minute that is left, I'm going to say that we support the budget that is tabled here, and we wish that it will bear the intended fruits of well-being for all South Africans. Thank you.
Thank you very much, Honorable Maisela. I call upon Honorable Kata.
Thank you, House Chairperson. It's a pity I cannot see the Minister. But Will Scope supports the ideology and the morality behind the push for universal health care. The national health insurance model currently being pursued by the African National Congress's government is unaffordable and too dependent on high economic growth levels which we do not have or we will not have under this current administration. What is urgently required is a back-to-basic approach. In this regard, it is telling that the department spent 99.4% of its budget in 2015-16, but only achieved 64% of its budget. In getting back to basics, we need to ensure that our hospitals and vital equipment are repaired and maintained, ensure that more clinics are developed, especially in our impoverished communities, resolve our underspending in the primary healthcare programs, improve our governance and management systems, resolve the dysfunctionality of our nursing education system, and attend the development of our clinic workforce. We need to resolve the medical internship placement program problems faced and resolve the inhumane working hours that we expect from our doctors. A far worse and more heinous and immoral crisis exists within many of our provincial departments of health in respect of their findings or their failings and in many instances unacceptable and inhumane delivery and non-delivery of a basic and fundamental service. Gauteng faced the Esidimeni tragedy, but in KwaZulu-Natal, there's a critical shortage of doctors and massive vacancy with just 2 oncologists and 2 radiologists and 2 urologists serving the entire eThekwini region. Neonatal mortality has increased. A report regarding specialized TB hospital, St. Margaret's, said that all wards are non-compliant to the National Core Standard Infection Prevention and Control. This while KZN remains the epicenter for TB in the world. And then we don't even have N95 masks available. The province only has 129 functioning ambulances, despite them needing 1,057 for its population size. To make matters worse, they are being dilapidated, aging, and even being stolen. Broken radiotherapy machines and a crumbling oncology service continue while people are dying excruciating and untimely deaths. Unfortunately, I do not have sufficient time to deal with all the provinces, but Minister, I did send you a pile of emails with complaints from doctors what is actually happening in hospitals. Minister, COPE has asked you numerous questions during 2017, which all came from doctors in the government service. From within your hospitals, it is clear your department does not know what is happening in our hospitals, and they are not informing you of a true state of affairs. Please check those emails. I want to quote one of the Limpopo doctors who responded to your reply to the questions. His MECs, and I quote, his MECs and heads of departments are hiding information from him. If he doesn't descend from Mount Olympus and go visit these hospitals, he will continue living in an delusional state where all is well. I challenge him to visit only hospitals in Limpopo and then still confidently say there is the necessary equipment. Minister, I'm going to make these responses available, which I have. But we cannot support this budget
Can you take
vote.
a question?
And I call on you, Honourable Minister, to ensure that operational life-saving equipment are made available and that we refocus on getting the basics right. Thank you, Minister.
Thank you very much, Honorable Carter. I call upon Honorable Kosa.
Thank you, Honorable Chairperson. Honorable Ministers, Deputy Ministers, Honorable Members, our guests in the gallery, Deputy President, the Madekwan. Allow me, Chairperson, to begin by saying that as the ANC, we support this budget. We support this budget, Chairperson, because we understand what it entails. Honorable Chairperson, Chapter 10 of the National Development Plan states that South Africa's health challenges are more than medical. Our behavior, lifestyle also contribute to ill health. To become a healthy nation, South Africa needs to make informed decisions with regard to what they eat, whether or not they consume alcohol, and their sexual behavior, among other things. Honorable Chairperson, Vision 2030 of the NDP enjoins all of us to embark on the trajectory to reforms the health system to ensure that all South Africans have access to comprehensive health system and services, regardless of their financial status. To this end, the NDP foresees South Africa achieving the following, Chairperson. 1, raising the life expectancy to at least 70 years. Ensuring that generation of under 20s is largely free of HIV/AIDS. Significantly and reducing the burden of the diseases. And lastly, reaching an infant mortality rate of less than 20 deaths per 1,000 lives. Honorable Chairperson and honorable members, South Africa's transition from apartheid era to the democratic dispensation has not been easy. The transition connected with repealing various pieces of legislation and discouraging institutionalized discrimination on the basis of race, color, gender, religion, culture, sexual orientation, and the financial status. For these freedoms, we struggled hard to attain and continue to do so for the improvement of our people's health. Honorable Chairperson, the right to health is fundamental to the physical and mental well-being of all individuals, and it is necessary condition for the exercise of other human rights, including the pursuit of an adequate living standard. The right to health is provided for in 3 sections of the Constitution. These provide, Chairperson, for the access to health care services, including reproductive health care for the children, and emergency services, basic health care for the children, as well as the medical services for the detained prisoners and persons who have been detained and also prisoners. The universal access is provided for in Section 27(1)(a), which states that everyone has a right to have access to health care services, including reproductive health care. Section 27(1)(b), Chair, directs the states to take reasonable legislative and other measures within its available resources to achieve the progressive realization of this right. The aforementioned is also unsaturated, Chairperson, by the Constitution of the World Health Organization, which states that the highest attainable standard of health is a fundamental right to every human being, including the access to timely, acceptable, affordable health care and the appropriate quality. Honorable Chairperson, the ANC believes that a healthy nation is a wealthy nation. Hence, it strives for the accessible, quality health care for all. In this context, let me remind this August House Chairperson of some achievements this ANC government, through the National Department of Health, has attained. They are as follows. Improved health infrastructure through the revitalization of the grant, that is 1. 2, improve reduction of child and maternal mortality rates, increasing life expectancy, successfully piloting the NHI at health districts in South Africa, to mention but few. We also speak, Chairperson, of increasing the construction of the refurbishment of hospitals, such as Lady Brand, Jamestown, Mamelodi, and many more, but I will just mention few of them. We also, Chairperson, championing the HIV response by increasing the ARVs. We increase, Chairperson, the medical circumcision for those that are volunteering to do such things. Honorable Chairperson and honorable members, let me remind this House that this budget vote is requested from, among other things, the following. One is to enroll 1.5 million patients on centralized chronic medicine dispensing and distribution system for receiving medicines. Finalizing new maternal, newborn, adolescent, women's health, and the National Health Committee, and to distribute to provinces. Reduce the under 5 mortality rate, revitalizing 8 hospitals, 42 clinics, and community health centers. The other issue, improving communities' access to primary health care facilities. Honorable Chairperson, in pursuit of meeting these strategic objectives over the MTF period, the National Department of Health will continue to build on the solid foundation of progressive pieces of legislation that this August House has passed to transform and re-engineer the health sector of this country. Henceforth, this department will remain steadfast on delivering quality, good health care over the curative approach, improving health care practitioners, reducing the medico-legal claims, and improving the number of primary health care facilities, which meet the standards of an ideal clinic to ensure that the services rendered to our people are efficient and are of higher standard. This budget, Chairperson, will enable this department to ensure that health services are patient-centered and continue to ensure that its human rights services are accessed by all South Africans, particularly by the most vulnerable and the poor. Honorable Chairperson, South Africa is far better than prior the democratic dispensation. The life expectancy has significantly increased and access to healthcare facilities have improved. Over the years, this department has introduced various reforms and responses to various diseases and determination of the health. The following, Chairperson, are some of the grand interventions this department has introduced. They include: 1, reducing mother-to-child transmission; 2, home and community-based care, which was created to manage and care for the people living with advanced HIV and AIDS and orphans, as well as people living with physical or mental disabilities. This intervention was mainly introduced to relieve the pain and frustration of family members of the people with difficult health problems, such as the advanced HIV. Hence, it is focused on provision of palliative care in the home or at the community level, which still happens today in partnership with the Department of Social Development. Honorable Chairperson and honorable members and our guests, this department is alive to the challenge confronting South Africa today. To demonstrate this, the department has created innovative programs such as the following: 1, Mom Connect, empower women with information on pregnancy, provide content on nutrition, exercise and drug, and dangers of drinking, smoking, and drugs. And lastly, Chairperson, provide information on safe sex during pregnancy. Honorable Chairperson, our distinguished guests, economics has taught us that scarcity problem, that with minimum resources, we can try to satisfy unlimited needs. Hence, this budget is approved by the African National Congress. It is against this backdrop, Chairperson, that all of us, the members of Parliament, should demonstrate our commitment towards provision of equitable, sound, and most efficient healthcare services to all South Africans by voting in favor of this budget vote. The ANC support this budget, Chairperson. Thank you very much.
Thank you, Honourable Member. The next speaker is the Honourable Minister of Health.
Thank you very much, Chairperson. Chairperson, in the gallery today, we have got guests, relatives of the Life Isidimeni patients, those who perished and those who had to be relocated. I wish to take this opportunity to thank them heartily because we would not have done the work I've reported without them. They worked with a team of 60 specialists to decide where the patients must move to by going to examine the areas, how do they move, the mode of transport, how many, etc. May I take this opportunity to ask them to stand up, please? We brought them here to understand how the healthcare system works because we still need them as we're entering the last and very decisive phase of closure on the Life Isidimeni saga. There are two things that are left. I've just told you the NPA has just requested all the files because they want to start conducting inquests into the cause of death and start prosecutions of people who need to be prosecuted, and the families will work with us. They worked with us to start implementing Recommendation 17, which said we need an alternative dispute resolution mechanism by appointing a credible South African to lead that process. We've worked with them. We've already appointed that person who's an honorable judge, but I have not yet announced the name because certain processes need to be done. They are going to have to sit with the judge to go through this process. So we still have got a long journey with them. And that's why I need to thank them, and I thought it was important for them to be with us here. Honorable James, you said I mentioned somewhere that I'm going to push with NHI despite objections. It was true over the weekend. I was taking journalists for 2 days through this whole concept of NHI. They never said there are objections. They said there's a pushback. Minister, what are you going to do when there's a strong pushback from those people who don't want NHI? I said I'm going to go on because every country that implemented universal health coverage, there was a pushback from the rich. When President Obama introduced Obamacare, there was a big pushback from supporters of Donald Trump, who even now have reversed it now that it's gone. So there will always be a pushback. When Britain started implementing the system in 1948, there was a pushback. When Japan did in 1961, there was a pushback. When Mexico did in 2001, there was a pushback. Here in South Africa, there will be a pushback. But it doesn't mean we'll stop. We'll continue implementing. And Honorable Carter is saying this is going to be expensive. Let me tell you, my dear, the most expensive system is what we are doing now. It's not NHI, it's what we are doing now. And even the World Organization has said so. Because how do you explain a situation where a country is spending 4.4% of the GDP on only 16% of the population? That system cost us, the private healthcare system under the present system, cost 40 billion rand in 2002. By 2014, it was already 140 billion rand. Just for 16% of the population. That is what is expensive, not NHI. NHI is not going to go anywhere nearer there. So you need to understand, and I will tell you why you are saying so. Every time we want to serve the poor, we are told that is going to be expensive. But when the rich have to be served, it's okay. And the figures are here. That's why we're called an outlier. And let me tell you, there's no other country, and I'm repeating, there's no country in the world that is spending so much money for so few people. So we need NHI to equalize, and we'll never pull back. We are going to go on. The last issue I want to say about the tax credits, Honorable James, I'm not sure whether I understood you, but I saw it in your own document, which is called our health plan. This issue of tax credits. If you are also doing a illegal thing, because it's a proposal which I saw. Because on that one, I agree with you, but when you say it's illegal, is your document illegal? I'm very surprised. Yes, I'm very surprised because I saw it on page 1 of your document. Even though the mistake you made was that you said tax credit are 17 billion taken back to the rich, and you will say you will take them to the poor is social justice. The only mistake you made is because it's not 17 billion, it's 20 billion. Yes. But it's not going to be illegal. It's a new policy, unless you are saying our policies are illegal. Universal health coverage is not illegal. It was adopted by United Nations on the 5th in September 2015. And all 194 countries have endorsed it. So countries must implement it. And if we implement and people push back, we'll fight because we're part of the endorsement. It's one of the 17 Sustainable Development Goals of the United Nations. All I was saying is when we start, we are identifying money that is going to the rich. We want to serve the poor. And the rich are me and you.
Honourable Minister, you have a minute.
Thank you very much.
No, thank you, Honourable Minister. Honourable members, that concludes the debate and the business of this mini plenary session. The mini plenary will now rise.